Today we're going to talk about the patella and the elbow and some of the trauma views that you can do in those situations. The guy on the left here is an Olympic weightlifter from a few years ago who was lifting 326 pounds and his elbow popped completely out of the joint. That was kind of gross looking. It's all bent backwards on that picture. And on the picture on the right, this is about the only Settegast projection position that wasn't included in Merrill's. And you'll see when we get there what I mean. There's a million different ways to do them. Here's your elbow anatomy reminder. So the elbow joint proper is made up of humeral ulnar joint, humeral radial joint, and the proximal radial ulnar joint. So sometimes you'll see it listed just as an elbow, and other times you'll see it listed as these other joints. Okay. Here's the lateral. The lateral anatomy will be the most helpful for the Coyle method anatomy when you're looking at the images. All right, general position for the patient. Sitting at the end of the table is usually the easiest way to do these. And of course, the reality is you'll have to figure out ways to get some of your positions done using your creative gene if you've got a trauma or people who can't move around very easily. So you'll have to think outside your box. First, we're going to talk about the axiolateral Coyle method for the elbow. For this view, you're going to use 40 inches SID, small focal spot, 5 by 5 tight collimation, 8 by 10 or 10 by 12 image receptor size. You're going to center at the mid-elbow joint. And be aware there are two different flexions that you're going to use for the Coyle method, depending on which part of the elbow you're trying to see, and you'll angle the tube two different directions. So if you're going to do the Coyle method for the radial head, you're going to flex the elbow 90 degrees, and your hand will be pronated. So that's different from when you're doing a regular lateral elbow because your hand is upright. So your hand is going to be pronated for these two views. So you're with the radial head Coyle method, 90-degree flexion, and your central ray is angled 45 degrees toward the shoulder or toward the head. So I try to remember it is if you're doing the Coyle method for the radial head, you're going to angle toward the head. If you're doing the axiolateral Coyle method for the coronoid process, you only flex the elbow 80 degrees. Your hand is still pronated, but you're not quite at 90 degrees. You're going to bring it out to more like 80 degrees. So I want you to think about why you might use only 80 degrees for that view. I'm going to ask you that on your quiz, so be ready for that. So with the Coyle method for the coronoid process and the 80-degree flexion, your central ray is angled 45 degrees away from the shoulder. So you're doing the opposite direction with your central ray from the shoulder to do the coronoid process, to include the coronoid process. Here's a good example of what that looks like. So for the radial head, you're going to angle toward the head or toward the humerus. And for the coronoid process, you're going to angle away from the humerus, away from the head. If you've got a patient who's lying down, you're going to do it this way, cross table. For the Coyle method, you'll do the same thing. So 90-degree bend of the elbow and angle 45 degrees toward the head when you want the radial head. And then you'll do 45-degree angle, 80-degree flexion for the coronoid process. This is what your image is going to look like. You can see the radial head really well, and it's separated from the capitulum. The second image down here, you can see the fracture of the radial head pretty well. This is your other Coyle method for the coronoid process. You can see the coronoid process right here. Looks pretty clear there. It's a really nice view of that. So what do you think is going to happen if you've got a 90-degree flexion rather than an 80-degree flexion? Okay. These next two views are acute views of the elbow. So you have acute view of the humerus, and you're going to center 2 inches superior to the olecranon. And when they're talking about that, they're talking about from the olecranon up the distal humerus that is flush with the image receptor. And your central ray is going to be perpendicular. So your image, you're going to be looking more at the humerus here rather than the olecranon and the ulna and the radius. So you want to be sure that you know which is which. So for the humerus, the distal humerus, you're going to be looking, your CR is going to be perpendicular. For the acute forearm, you're going to angle so that your central ray is perpendicular to the forearm. So there's no specific angle for the tube on this. You really need to look at your forearm and make sure that it's perpendicular to the central ray. And this view is for the proximal radius and the ulna. And you can see them really well through there. So in this case, you would use this view if your patient is unable to straighten their arm. So if they're stuck that way, then this is going to be an option for you in a trauma situation. Here's a review of the knee and the patella. When you do x-rays in pediatrics of the knees, many times you don't see the patella because they don't really develop until between 3 and 5 years of age. So when they're little like that, though, they're made of cartilage, so they're too soft to show up on the x-rays. They're there, you just can't see them. All right. So the patella projections include, if you're doing a non-trauma, you'll do a PA view. The closer you get the patella to the image receptor, the better, because there's a little better detail, of course, if you're closer to the image receptor. Tangential views do not usually specify any angle, as everyone is shaped differently, and patients have more or less flexibility in their joints. Their ability to move may be different. There are multiple ways to accomplish the tangential view. It's critical to know the patient's history, though, and limitations. If they've had a recent surgery, they may be limited. There may be limited ways that you can do the tangential without injuring the patient. So you want to make sure you communicate with the doctors just to make sure you know what the patient can and can't do before you have them bending all over the place. You always do a lateral of the patella as well. And the tangential views, the Settegast method has so many ways to do this one. I'll show you the pictures of them, but basically it's all the same view. It's just how the patient is sitting or laying down, or here's the lateral patella. It's slightly different from the lateral knee. The patella is not always perfectly aligned on top of the knee joint. So when it says to make sure that the patella is perpendicular to the IR, the knee joint may or may not be lined up straight, but you're opening up the patellofemoral joint space. So some people's patellas are more toward the lateral side of their knee. I'm sure you've seen that. So you may have to roll the patient's knee a little bit differently than you would if you were doing an actual lateral knee joint, so that you can see through the mid-patellofemoral joint space. Make sure your marker is up out of the way as well. Your collimation is going to be fairly tight on that area, so just make sure your marker's in the light field but not in the anatomy. You're going to position a little bit more anteriorly with the lateral patella than you do for a knee as well. So this is the first Settegast method. So just once again, be sure that your patient is able to bend their knee before you bend it. If they've got a transverse fracture across the patella and you bend their knee, you're going to cause them more harm than good. So patient can be prone. You don't really have a specific tube angle that's listed here. Once again, you're trying to get tangentially through the joint. So if you get your patient to bend their knee approximately 90 degrees, you can use the band to have them hold their knee, their ankle forward toward their back, and then angle your tube 15 to 20 degrees cephalad toward the head to get the beam, tangential beam, to go right through the patellofemoral articulation. The patella should be perpendicular to the image receptor, and your collimation is very tight. And once again, keep your marker out of the anatomy. So here are some options for the Settegast. So your central ray comes from below, tangentially through the joint. You can have them sitting on the table and you go tangentially through the joint. This is the one we just looked at with the knee bent. Here the knee's bent here and you're going up that direction. So it's pretty much the same position. You're just trying to get the image receptor is closest to the patella, and your central ray is angling through the joint space to the image receptor. This is called the Hughston method. It's also tangential. The book says not to rest the foot on the collimator box since there's the potential for the patient to get burned. And how do you think you can manage to support that foot without resting it on the collimator? I'm not sure. That's the way I used to do it, but there may be other ways to get that done without resting on the collimator box. This is very, very common view to do. It's the merchant view. There's a merchant board that is used, and it's also, oh, I forgot to tell you, it's also, this patellar view is also called the sunrise view. So you can see why it's called a sunrise view. Anyway, there's a strap on the board that you can wrap around the patient's legs that's going to hold their legs together and still. These arms come up on the sides and you rest the image receptor on the patient's legs and the bars that come up and hold the cassette in place. Your knees are bent 40 to 45 degrees. There's a significant OID here, clearly, so you need to increase your distance. So you're going to use 48 to 60 inches for your SID. You can see here because you're going to have some magnification if you don't increase that. Your OID is just too far in a merchant view. This is another one. It's called the Hobbs. Patient's sitting on a chair. Your central ray is perpendicular through the joint. You can see on this guy right here, you can see where tube is right here. It's going straight down. You just put your image receptor on a footstool. And this is what they look like. Here's a nice fracture on that one. So the whole idea is to get that patellofemoral joint space open tangentially. So you've got to really look at it and make sure you get your angle right through the joint.